Hi guys, we are now going to wrap up our endocrine unit with a discussion about the adrenal gland disorders. And the information is in Chapter 50 for the 9th edition, or Chapter 49 for the 10th edition of your book. Here are our objectives. We're going to identify the pathophys, manifestations, collaborative care, and nursing management of the patient with an imbalance of hormones produced by the adrenal cortex, as well as the pathophys, manifestations, collaborative care, and nursing management of a patient with an excess of hormones that are produced by the adrenal medulla. Now remember that the adrenal gland sits above the kidney, on both kidneys, and the medulla, adrenal medulla, is the middle part of the adrenal gland. The adrenal cortex is the outer portion of the adrenal gland. So let's start with Cushing's syndrome. Cushing's syndrome is a disorder when a patient is chronically exposed to corticosteroids, so they're receiving excessive amounts of corticosteroids, especially glucocorticoids. We know that the adrenal cortex releases 3 types of steroid hormones. We have the glucocorticoids, the mineralocorticoids, and then the androgens. The glucocorticoids regulate our metabolism and they increase our blood glucose levels. They are also part of our body's stress response. In Cushing's syndrome, you have this excessive exposure, and the most common cause is exposure to exogenous steroid therapy, so medications such as prednisone is a big one. Other causes can be from tumors, a tumor that is in the pituitary gland that secretes or causes a secretion of excess adrenocorticotropic hormone, or ACTH. There can also be adrenal tumors that can cause an excess release of cortisol. There can also be ectopic ACTH tumors, and that just means that they're located in another part of the body, especially the lungs and the pancreas. Those tumors can secrete this ACTH and cause Cushing's syndrome. This is a disorder commonly found in 20 to 40-year-old people, mostly women over men. So of course we know with endocrine disorders there's some kind of problem with the negative feedback loop. So here's our negative feedback loop showing the hormones that we are concerned with for the adrenal gland. Normally the pituitary secretes ACTH, and ACTH is going to act on the adrenal gland, and the adrenal gland will release cortisol in response to the ACTH. Cortisol will then have its effects in the immune system. The signs and symptoms associated with Cushing's are all related to excess amounts of steroid or corticosteroids that are circulating in the body. So there are many physical changes that occur. Weight gain is related to the accumulation of the adipose tissue in the trunk and the face. This is called moon face. Also, there can be adipose tissue deposited in the cervical spine area. They also call this a buffalo hump. The muscles begin to waste and legs and arms become kind of spindly and thin. There will be weakness. Bruising and thin skin will also happen as a result of a lack of collagen. There's also a delay in wound healing that is occurring in these patients. Purple striae is present, a common type of symptom present too that happens on the abdomen. It looks like stretch marks almost. It can happen elsewhere. But on the abdomen is a common location for that. The patient may also have some swelling, and that's a result from the sodium retention, from that excess mineral steroid, and with that sodium retention we have some fluid retention occurring. Here is a picture that helps us to see all of the effects as well. So I want to point out that some other very important side effects or symptoms to Cushing's syndrome are hyperglycemia, increased risk of infection or increased susceptibility to infection. There's an increased risk of osteoporosis because there's a change in the bone matrix that occurs with Cushing syndrome. And so those are all other important symptoms that we want to monitor for in Cushing's. Here are some pictures of the purple striae on the abdomen. You can see there's some on the arms. You can see the moon face, how that looks, the cervical spine adipose tissue on the man in the middle. The buffalo hump is the other name for that. And also babies can have Cushing syndrome. And so you can see this poor little baby has the moon face and the excess adipose tissue. The diagnostics that are used for Cushing syndrome are looking at elevated levels of cortisol. So we're expecting elevated cortisol levels. A 24-hour urine collection is done, and this test will measure the amount of cortisol in the urine. Anything above the normal range of 80 to 120 mics per 24 hours is considered increased. A salivary cortisol test can also indicate high levels of cortisol. Measurement of the ACTH levels can vary. So it depends on what the underlying cause of the Cushing syndrome is. So the levels can be low, they can be high, or they can be normal. There might be scans done, like a CT scan or an MRI, to look for tumors as the primary cause of the Cushing syndrome. And all of these tests combined will be put together to make a definitive diagnosis, also looking at the patient's health history. So the treatment goal is to decrease the hormone secretion to normal levels, and this will depend on the cause of the Cushing syndrome. For instance, if the cause is a tumor, removal of the tumor will be necessary. An adrenalectomy might be necessary if the tumor lives in the adrenal gland. They might have to go in and remove part of the adrenal gland. They might also do a medical adrenalectomy, which is a medication way to kind of wipe out the adrenal gland. And that's going to suppress the cortisol hormone as a result. If the development of the Cushing syndrome has happened due to exogenous steroid use, it will be important to change the schedule of administration of the steroids. If we have to continue giving them to the patient, we can change up how we give the steroid. For instance, we can reduce the dosage, we can give the med on an alternating type of schedule. And so that's kind of like a tapering effect to the steroids. Might need to discontinue the steroids altogether. It's important to monitor patients for infection, especially because they have an impaired immune function related to the excess steroids. We're going to be looking for signs and symptoms of infection and preventing infection. Also implementing safety precautions. Since there's a risk of injury, they have the risk of osteoporosis as a side effect. And patients with physical changes that have occurred from Cushing syndrome can expect to see improvement in those physical changes with treatments as their hormone levels normalize. That will be improved. So that's not anything that they will have to live with forever. So Addison's disease is the opposite of Cushing syndrome. In this disease, there is a lack of all three types of corticosteroids. So we have reduction in the glucocorticosteroids, the mineral corticosteroids, and the androgens, or the sex androgen hormones. This disease can be caused either from decreased functioning of the adrenal cortex, which is considered primary Addison's disease, or it can be caused from decreased secretion of ACTH from the pituitary gland. This is considered secondary Addison's disease. Most cases, roughly 80%, are from an autoimmune process that's occurring where antibodies are attacking the adrenal tissue. The disease is progressed at the time of diagnosis, typically, with about 90% or more of the adrenal glands destroyed. It's a slow, progressive illness. The patient will experience weakness, fatigue, with weight loss and anorexia. In patients with primary disease, there will be elevated ACTH levels, which causes skin hyperpigmentation in sun-exposed areas such as the hands, the creases of the hands, also over joints. There might be hyperpigmentation in the gums of the mouth as well. Patients that already have adrenal insufficiency are at risk for an acute exacerbation of adrenal insufficiency. And this is called Addisonian crisis. And we're going to talk about that a little bit more here. So Addisonian crisis is a life-threatening emergency that is triggered by some kind of stress or an illness, sudden withdrawal of steroid therapy. This can lead to an exacerbation of adrenal insufficiency. The signs and symptoms are related to the significant decrease in the mineral and glucocorticoid steroids. So you're going to see hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia, nausea, vomiting, diarrhea. So all of these, and the biggest thing is that the hypotensive effects are going to lead into shock, and that's where we really are going to have life-threatening issues. So labs that we'll be seeing for Addison's are low serum and cortisol levels. ACTH will be increased in primary disease because the problem is the adrenal gland and not the pituitary gland. ACTH will be decreased in secondary disease since the problem is the pituitary and not the adrenal gland. An ACTH stimulation test will be done when the patient has when there's uncertainty of what the cause is. They can give synthetic ACTH to see if the amount of cortisol improves from the baseline levels. This can further help develop the definitive diagnosis and determine what's going on with Addison's disease. Many times the patients will need to be on steroid replacement therapy such as hydrocortisone. This is going to replace both glucocorticoids and mineral corticoids that are needed in the body. This will be lifelong therapy that the patient will require. If the patient ends up in Addisonian crisis, the patient must be treated quickly because this is a very serious, life-threatening exacerbation of Addison's disease. The patient will have fluids to treat the shock symptoms and steroid therapy as well. And once treatment has happened and the blood pressure is stabilized, you will also see an increase in the sodium levels, a decrease in potassium levels, and an increase in the blood sugar levels. We also want to educate the patient about steroid therapy and the expected side effects. Since there are so many, we know that steroids have many complications and side effects. We especially worry about the suppression of the immune system and subsequent risk of infection. And this information is also part of our pharmacology lecture with steroids. So looking back at all those side effects and complications is a good reminder. We will lastly talk about a condition that is caused from a tumor in the adrenal medulla. The adrenal medulla is the middle portion of the adrenal gland, and it's responsible for the release of norepinephrine and epinephrine. So this condition is called pheochromocytoma, and this condition is extremely rare and can be very dangerous. The tumor in the adrenal medulla causes an increase in the production of catecholamines, the norepi and the epi. This can cause serious side effects in the body. This condition is mostly seen in young and middle-aged adults. So the most concerning sign of pheochromocytoma is extremely high blood pressure. The patient will experience a severe pounding headache, tachycardia with palpitations, profuse sweating. They could also have chest pain, abdominal pain. This extreme hypertension can lead to other problems if it's not treated quickly. And these problems are related to that increased SNS activation, so the sympathetic nervous system is activated. So you can have hypertensive encephalopathy, where you're having neurological effects from the high blood pressure, diabetes from the increase in the blood sugar, cardiomyopathy can occur from the stress on the heart, and then this can lead to death. So to treat pheochromocytoma, if it is suspected, we will give alpha and beta blockers to drop the blood pressure and the heart rates. It's important to rule out other causes of the high blood pressure because this is such a rare type of condition. We want to make sure and look at the full picture and rule out any other possible reasons for high blood pressure. The diagnostics that are used will be a 24-hour urine collection, checking for catecholamine metabolites. They're going to look for that in the urine. And then a CT scan or MRI will be used to look for tumors in the adrenal medulla. If it is determined to be pheochromocytoma, it will be important to prevent further release of catecholamines by being aware of triggers that can cause that. So one such trigger is palpation of the abdomen. This can actually cause a sudden release of catecholamines and will lead to a hypertensive episode for the patient. So no palpating the abdomen in patients that have suspected pheochromocytoma. The tumor will be removed if it is determined to be a tumor in the adrenal medulla. They will go in and remove it as part of the treatment plan, and this should cure the hypertension in most cases, although there are some people that continue to have hypertension even after the tumor is removed. Okay, that wraps up our adrenal gland disorders. Thanks so much.